This lecture focuses on pulmonary ventilation, the mechanical movement of air into and out of the lungs. Unlike the previous lecture, which emphasized structure and gas exchange, today we're going to rely heavily on quantitative reasoning. Ventilation is governed by physical laws, not intuition. To truly understand ventilation and ventilatory failure, we must be comfortable with equations, pressure relationships, and volume changes. Physiology is a quantitative science, and respiration is no exception. This slide introduces the Fick principle as an example of how oxygen consumption depends on blood flow and oxygen content differences. Importantly, ventilation does not occur in isolation. It must ultimately support tissue and oxygen demand. Being able to rearrange and interpret equations like this is essential for understanding exercise physiology, shock, and cardiopulmonary disease. But what does it mean? Calculations are only useful if you actually understand what the numbers represent physiologically. When we calculate VO2, we are quantifying how much oxygen tissues actually extract from blood. Throughout this lecture, ask yourself not just how to calculate something, but what it tells you about the patient or the system. The Fick equation defines tissue oxygen consumption as the product of cardiac output and the arteriovenous oxygen content difference. So we can see here we have VO2, which is oxygen consumption, equals flow or cardiac output times the difference between arterial oxygen and venous oxygen, or the amount of oxygen in arterial blood and the amount of oxygen in venous blood. This equation reinforces a central concept. Oxygen delivery depends on both ventilation and circulation. You can have perfectly functioning lungs, but if cardiac output isn't adequate, oxygen delivery will still fail. This framework will reappear later when we discuss ventilation efficiency. Fick's law describes how gases diffuse across membranes. Diffusion increases with surface area and pressure gradients and decreases with membrane thickness. The diffusion coefficient represents gas solubility and molecular weight, explaining why CO2 diffuses more easily than oxygen. Remember, CO2 has an easier time moving across the membrane than oxygen does. This law, Fick's law, underpins everything from alveolar gas exchange to diffusion impairment in fibrosis. Now, there's not just one law, there's many laws that govern the respiratory system. Ventilation is constrained by fundamental gas laws. So Boyle's law explains airflow during breathing. Charles' law explains temperature-dependent volume changes. Dalton's law allows us to calculate partial pressures of gases, which is essential for determining inspired oxygen concentration. And Henry's law explains gas solubility in the blood. These are not abstract. They directly explain clinical phenomena such as hypoxia at altitude and oxygen therapy. So there are some key common notations that are helpful to note when you're learning about respiratory physiology because it uses dense notation and fluency with these symbols is really essential. Subscripts indicate location, arterial, venous, alveolar, for instance. Um, or even inspired. Superscripts indicate gas type, and misinterpreting a symbol can completely change the meaning of an equation. Mastery here helps to prevent errors later when interpreting blood gases or pulmonary function tests. So you can see here, for instance, there's a symbol px. This is the partial pressure of X. For example, the partial pressure of CO2 would be the partial pressure of CO2, carbon dioxide. So that's how some of these things are read. And then these are the different locations. A lowercase a is indicating arterial versus a lowercase v is indicating mixed venous. An uppercase A is alveolar. A lowercase c is pulmonary capillary blood. And then an I, capital I, is inspired gas versus a capital E is mixed expired gas. And you can see how these are used here. So PA is giving us the partial pressure of arterial blood of specifically carbon dioxide versus PV, CO2, is the partial pressure of venous blood. And PCO2 is the partial pressure of arterial capillary blood of oxygen. PaO2 is the alveolar oxygen partial pressure. So this is how you'd read these things. Before we even get into how the lungs work, we're going to review some basic science going back to the properties of gas. The pressure is defined as force per unit area. In respiratory physiology, we distinguish between absolute pressure and gauge pressure. Most respiratory pressures are described relative to the atmospheric pressure, and this distinction is critical. For example, intrapleural pressure is negative only because it's lower than atmospheric pressure, not because it's truly zero. So atmospheric pressure is kind of the number that we're comparing all of our other pressures to. Now, we do have some gas laws. The ideal gas law is one of them here, and I have the definitions of these components. The ideal gas law relates pressure, P, volume, V, temperature, T, and the amount of gas, N, moles of gas. While biological systems are not perfect gases, this law provides a conceptual foundation. When temperature and gas quantity are constant, pressure and volume become inversely related, a relationship that directly explains ventilation mechanics. So if we look here, we can see the derivation for Boyle's law of P1V1 equals P2V2. And this is by holding temperature and gas quantity constant. The ideal gas law will simplify into Boyle's law. This tells us that pressure varies inversely with volume. This is the single most important physical principle underlying pulmonary ventilation. Every breath you take is an application of Boyle's law. Increasing volume decreases pressure. Decreasing volume increases pressure. During inspiration, thoracic volume of our thoracic cage increases. Our alveolar pressure drops, and that allows for air to flow in. During expiration, the reverse occurs. Importantly, gas flow occurs only when a pressure gradient exists. If there's no gradient, if everything's equal, there's no airflow. At rest, atmospheric pressure and alveolar pressure are equal, so no airflow occurs. This equilibrium represents at the end of inspiration or expiration. Ventilation is therefore a dynamic process of repeatedly disturbing and reestablishing equilibrium through volume changes. This slide visualizes Boyle's law in action during inhalation. We can see rest on the left and inhalation on the right. As thoracic volume increases, which is our green, alveolar pressure falls below atmospheric pressure, creating a pressure gradient that drives air into the lungs. Importantly, air does not get pulled into the lungs. It moves passively down a pressure gradient. This distinction becomes critical when we later discuss ventilatory failure and mechanical ventilation principles. And you can see this process occurring. So we're going to talk more on this whole process later. We're going to return to the pressure relationships in more quantitative detail after establishing some initial mechanics of ventilation. The key takeaway here before we move forward is that ventilation is a mechanical process governed by pressure-volume relationships.